I was diagnosed with COVID,
Uh-huh.
and my doctor sent me to ER today for the simple fact that I have headaches and fever that wouldn't go away for the past 3 days. So he said it would be best for me to come to the ER and see if they could do a further evaluation.
I was diagnosed with COVID on the first.
Uh-huh.
Um, I was treating it with this vitamins and tonic water and stuff, and Tylenol and Mucinex. I was feeling okay until today, where I was laying down and had shortness of breath on the couch. Got up, felt a little woozy. Um, got my O2 meter, checked myself, and it was 87 to 88.
Well, unfortunately, we're back. It's December 16th, and those were some of Jess's patients and some of Swami's chest x-rays. And it feels like we are back where we were in April, except this time it's in different parts of the country, although it's kind of everywhere. We've got a lot to cover tonight. Some really important stuff about the vaccines, also some really important stuff about palliative care and crisis standard of care stuff. So let's just sort of get straight into it. This image here is of the Washington modeling. And if it's correct, it shows you that California is going to be projected to need about 5 times more ICU beds than we have. Obviously, that's not going to happen. And people think the solution is this, just get more beds. But of course, that is not the problem. The problem is we need thousands more Sarahs and tens of thousands of more nurses, and that's not going to happen. So creating of beds is not the solution. You just can't do that. Now, a lot of people who are not physicians, not clinicians, watch this show. And I want to try and explain to you why that feeling that you're having, that things aren't so bad but they're terrible, is correct. If you go outside, it's not like the Middle Ages. It's not like the Black Death. It's not like there are people, in the streets dead. And yet, at the same time, when you go into the hospitals, it's really quite terrible in lots of parts of the country, particularly in California right now, and particularly in the LA area. So here's an animation that tries to explain why it can be not bad, but terrible at the same time.
Not that bad, yet terrible. So you've heard some people say that COVID-19 is not that bad. You've heard others say it's terrible, and certainly public health experts across the world sure are acting like it's bad. Well, if you're confused, that's okay, because this pandemic is exactly not that bad, and yet terrible at the same time. Why is it not that bad? Well, compared to the first SARS outbreak, the current mortality of COVID-19 appears to be around 0.5%, which is not that bad. The first SARS virus had a mortality of 10%. Imagine 1 in 10 people that got infected died of that first SARS virus. Not that bad if you compare it against the 1918 pandemic. That had a mortality estimated at around 2.5%, or about 1 in 40 people infected. And that virus was really bad for people between the ages of 20 and 40, leaving millions of children without parents. I mean, that was horrible, really horrible. So compared to those outbreaks, COVID-19 is not that bad, right? Well, maybe, but it's still bad. Here's why. It's really infectious. It spreads pretty easily, especially when we're close and when we're inside. Lucky for us, the first SARS virus was not that infectious. It actually killed mostly healthcare workers in close contact with very sick people. If it was as infectious as this SARS virus, it would have made the 1918 pandemic look like a sunny day at the beach. So with a mortality of around 0.5%, and we don't actually know the exact number yet, and we won't until we get to the other side of this thing, and some people think it could be much higher than that, it's not that bad. Except it is. Let's just look at the US population of around 330 million people. 0.5% of 330 million people is 1.65 million people. That's the number of people that could die in the US alone if we just let this virus rip through the population, as some has suggested. That's a staggering number. Heart disease, the leading cause of death in the United States, kills just 650,000 people a year. But it mostly kills old people, you say. So it's not that bad, right? Well, even if you think the mass extinction of the greatest generation is no big deal, it doesn't just kill the elderly. Again, if we look at that 20 to 40 age group, it's true. The mortality in that group is only about 0.1 to 0.2%, right? Again, not that bad. Except that there is 160 million Americans in that age group. And at the low end, left to itself, it would kill between 160 and 300,000 young people. And here's the thing. All these people don't just die at home. They get sick. They go to the ER. If they're really sick, they get admitted. If they're really, really sick, they go to the ICU. The number of patients that would come to the hospital without mitigation measures like closures of bars and indoor dining and mask wearing and social distancing would overwhelm first the ER, then the ICU, then the staff, then the hospital, then the entire hospital system. Doctors and nurses get sick and cannot work. Those that are left are overwhelmed. All elective surgery stops, then all surgery. Then the trauma centers can't see patients anymore. There's no ICU beds. There's no one to look after them. Heart attack, sir? Sorry, we're overwhelmed. You're going to have to sit in that chair with all the other patients. Try not to die. And we actually saw this. We saw this in Italy. We saw this in South America. We even saw it in parts of New York. And if your hospital system doesn't work, what does that do to your economy? Do you risk driving or going to work or leaving the house, knowing that an otherwise not so bad accident or broken leg or stick in the eye could be fatal? Do you go out knowing that the virus is raging and there's no bed for you in the hospital if you get sick? So it is true, if you're young and healthy, your chance of dying or getting really sick is not that high. But does that give you much solace knowing that everything around you could collapse? And every now and then, one of your young and healthy friends will actually die. So yes, COVID is not that bad, but it's also terrible. And now the vaccines are so close. If we slow the spread in the next few months, we can save the healthcare system and get vaccines to millions of people. Vaccines that are truly remarkably effective at reducing the mortality of this disease. Reducing it by a kind of staggering amount. And as Dr. Fauci said, you don't want to be the last soldier killed right before they call a truce. The war will be over soon. The vaccine cavalry is coming. Now is not the time to be callous and get shot, or worse still, get someone else shot. So wash your hands, wear the mask, don't gather in groups. COVID-19 is not that bad, but it's terrible at the same time, and Armistice Day is coming soon. So let's do these last few months together, and when I say together, I mean 6 feet apart.
So that fantastic animation was by Graham, who's here running the show, and I hope that helps you to understand and maybe share it with friends, relatives and stuff, that this is, again, not that bad, but absolutely terrible. So let's do some good news. The FDA has just authorized this test. This is a home test. This is the first one of its kind. There are other home tests, but you have to send them into a central lab. This one, you basically do a swab of the nose, you put it into this sort of pregnancy test-like thing, and you put in some reagent, and it speaks to your smartphone via Bluetooth and gives you a result in about 15 minutes. According to the filings with the FDA, this has a sensitivity and specificity that's really, really high. So high that I'm not sure I believe it. But this is going to be something that we'll be getting in January. Unfortunately, it's not one of those tests that's going to be $1 or $2 as we'd hope. This is going to be about $30, but this could be particularly useful for certain groups of people. Other good news, these are the diplomats from Kenya that are at Aga Khan University, and there's Ben Wachira there on the left, and they're going to be your colleagues in the next few years. They're doing a diploma in emergency medicine, which is really exciting. And this is Britt and Ryan Ernst, who have been helping train these wonderful colleagues of ours to be. So other good news, we're looking in the chat room here, and a lot of you have gotten the vaccination. I want to show you a quick video of Mike Winters, who got the vaccine just yesterday.
And I'm just going to ask you to hold that for me for a second. Just hold that for me so I can get into position. It doesn't slide back down again. Yeah, I know. Relax your arm and your shoulders. That's when you relax.
I am relaxed.
Okay. Big muscles. You go beyond that? Oh. Let me do that. All right. Just throw it. Sticking out. Right? Yep. 1, 2, 3. So and then maybe our basis of the find those persist. Or they're a certain region. in your right extremity. Did it hurt?
Not at all.
What did it feel like?
It felt certainly even less painful than the annual flu shot. So, very easy. Regina did a great job.
Regina's gonna be famous. I want that vaccinator.
So this is really great news that the cavalry is coming, and yes, Mike looks like Mel, looks like Stuart. It's my thing. Every white guy that loses their hair, we all look the same. We have to do words that Stuart uses as well, because we did this at the beginning. We need to continue it before we get really heavy in tonight's viewing. So let's do words that Stuart uses.
I can't believe you didn't know that.
So we've got to keep it going. We're going to do another words that Stuart uses that you don't know. But I didn't really have one. So I just asked Stuart, hey, Stuart, have you got a word for me? And immediately like that, he said, use supercilious. And I'm like, of course, supercilious, which means, obviously, super silly. It obviously means that because it's in the word. But if I look over here on the dictionary, it says that supercilious means behaving and looking as though one thinks one is superior to others. Oh, come on. That's clearly wrong. Supercilious clearly does mean supercilious. I mean, please. That's ridiculous. So there's lots of questions in the chat room about whether there'll be links to particularly the animation that Graham made. Yeah, there'll be links to all of this stuff. We'll be sending it out in the next few days. And as soon as this is over, it'll actually be live again on YouTube as well. So now let's do a C3 update. And one of the big things to tell you is that COVID-19 chapter is going to come into C3 in audio form. And that should happen in the not too distant future. But we've got some other updates that Jess is going to tell us about.
I want to give you a brief update about COVID and C3. This is my son, Miles. And first, I want to give you an update about COVID and us, because this little guy is a COVID patient. A couple days ago, he developed a fever. He was febrile for a couple of days, grumpy, not feeling well. He's doing much better now. He had a positive COVID test, which means I have asymptomatic COVID. So Miles, can we give everyone a little update about C3 COVID? Can you say yes? Yeah? No. Okay. Well, here's the update. In a couple of weeks, we're going to be releasing an audio episode from C3 all about the approach to COVID. And so that should be out really soon, and it's going to cover everything ranging from the very sick crashing patient to the well who can go home dischargeable patient. We have real patient cases, and we cover that comprehensive approach. Now, if you're wondering what C3 is, well, you should totally check it out. It's one of the core programs that we offer as part of your EMRAP subscription. It's been around for several years, and it used to stand for Continuous Core Content. Now it stands for Comprehensive Core Curriculum, because we've been spending the last year working to realign it so it lines up with CorePendium. So instead of writing written summaries from scratch, we're using the CorePendium chapters, and that's going to be not only your written summary, but our guide as we go through the episode. So we're going to be developing this over the next few years. In total, there's going to be about 60 topics covering all of the core content of emergency medicine, the really common stuff and the really dangerous stuff. And it's going to include real patient cases, and we're going to be following the CorePendium chapters as our guide. That's right. And it also comes with a website redesign. Now, when you go to the C3 website, this is what you're now going to see as the landing page. Beautiful new redesign featuring our latest episode up here. And everything is sorted by section now. So you could go up to the search bar and do a keyword search for the topic you're looking for, or you could go to all topics and everything's going to sort by the section. And these correspond to the same sections as CorePendium. So you could search by section that way and go to the episode that you'd like, or you can scroll through, as for example, we have here in cardiovascular disorders. You could go to see all, or you could use the arrow and scroll across. Let's check out the episode on CHF. So you could play the episode directly in the player here. Scroll through the chapters. The written summary that was originally created is right here, but this also is a link here to the CorePendium chapter on heart failure. And in chapters where we have media, so let's go to the CHF exacerbation chapter. Now we have the chest x-ray, the ultrasound, and a video of how to measure JVD. And these are all nicely linked right here. By the time we're done with the entire C3 curriculum, it's going to be about 60 topics of all the core knowledge of emergency medicine, because this is your comprehensive core curriculum for emergency medicine. And yes, sometimes it's funny. Mama. Yeah.
I think young Mr. Mason stole the show there. COVID-19 updates in CorePendium. You know, we started this thing at the beginning of the pandemic. We are updating it constantly. Crystal Ives and Britt Guest, the lead authors, but they're getting lots of help from lots of associate editors and other people. So Britt is downstairs, physically distanced, and she's going to give us some of those updates. What do you got for us, Britt?
All right. Hello, everyone. I'm back again with CorePendium COVID-19 updates. So one thing that I want to add is we have put in a lot of information into the treatment section. I'm not going to review any of that because it's going to be touched on later in the segment. So just know all of those updates that we're going to review on the live show are in the chapter, but I won't talk about them here. All right, so first thing I want to talk about is an article that comes from the CDC, and it's on the use of the cloth masks that we are all so used to wearing at this point. So what we know about these masks is that if you're infected, you wear the mask. It prevents the spread of disease by preventing the respiratory droplets from spreading. What this article adds, though, is it seems that the mask actually protects the person wearing the mask by basically offering some degree of filtration of these viral droplets. So by filtering those droplets, it prevents the person who's wearing the mask from inhaling the infectious particles. How effective this is probably depends on the type of cloth that the mask is made out of, and at this point we don't know which material provides the best filtration, so we'll need some more research on that. But it does look like we've got some degree of filtration with just the cloth mask that we're all wearing in the community. Another thing I want to talk about, I've got a couple articles on obesity and mortality. This first article is a retrospective study. It's from Kaiser in Southern California, and it was a big retrospective study of 6,000 patients with COVID. And essentially what they showed here is obesity is strongly associated with an increased risk of death. And this risk of death was most significant in our younger patients that are obese. And what they found in this study is that once your BMI is above 45, that was associated with a 4-fold increased risk of mortality. So pretty significant. Another paper on mortality and obesity. This looks at BMI. This was another study out of New York, 2,000 patients, retrospective study. And what it basically showed is as BMI increases, so does the risk of intubation. And I think what's interesting about this paper is that obesity was associated with an increased risk of intubation and mortality in patients under 65, but not over 65. I was a bit puzzled by this at first, but I think the point here is once you get older, once you're 70, 80 years old, your age, that you become more frail, your immune system is weaker, that in and of itself increases your risk of mortality more than probably the obesity alone. This paper is on heart failure, just added to the cardiology section, and it was a big study out of New York again, 6,000 patients, and essentially it showed that patients with a past medical history significant for heart failure had double the risk of mechanical ventilation and mortality. And I think the interesting point in this paper is that increased mortality risk was independent of left ventricular ejection fraction. And I think for a lot of us, we might assume that if we have a patient with COVID, they have a history of heart failure. If they have a preserved EF, you would think that their risk of mortality was probably lower compared to somebody with a reduced ejection fraction. But this paper, and along with a few others, really points out that the risk factor is just the heart failure alone and independent of the actual ejection fraction. This paper is an update on ECMO from The Lancet, and this basically was looking at the mortality of COVID-19 patients that needed ECMO. Now, prior to this paper coming out, it was a big study, 36 different countries, big international study. I would have thought that if you were so sick with COVID and you needed to be put on ECMO, that your mortality was probably pretty high. Honestly, I would have guessed somewhere in the 80s. But this paper showed that the 90-day mortality of patients with COVID requiring ECMO was actually less than 40%. So I think this is a lot lower than most of us had previously predicted. And I think what this indicates is, I think the results really support the consideration of ECMO in hospitals that are experienced with ECMO and have the ability to take care of these critically ill patients. Now, this is a paper that we just added to the neuro section, and this is cerebral venous thrombosis in patients with COVID-19. Now, I want to start by saying this was a systematic review from Singapore. It's a very small study. It's only 14 patients. I mean, there's not that many patients with COVID and cerebral venous thrombosis. But it looked at these 14 patients. It showed a median age of 43, a little over half were male, over half of them had no medical problems. So we're looking at a pretty young patient population that seems to be pretty healthy. The spectrum of disease, it looked like about 1/3 had mild COVID symptoms, 1/3 had moderate infection, and another third had severe infection. And what they found was, in these patients with COVID who developed a cerebral venous thrombosis, their mortality rate was about 45%. This is really high. If, just as a reminder, cerebral venous thrombosis without COVID has a mortality rate of about 15%. So although this is a really small study and very limited data on this, for me, I think the take-home point was, if I have a patient with COVID with unexplained neurological symptoms or just a headache that doesn't make sense, I really think it's important to keep venous thrombosis on your differential, since it seems to be associated with a pretty high mortality rate. Now, I know we're also going to talk a lot about palliative care in this live session, so I don't want to take too much time, but I just want to mention we have added a palliative care section to the book chapter. I think it's excellent. It gives a lot of information on non-pharmacological interventions, addressing isolation, emotional support, tricks for managing dyspnea, delirium, terminal bleeding, and how to really just provide excellent care to our palliative care patients during a pandemic. So with that, I think those are the COVID updates. So back to Mel.
Thanks, Britt. Already in the chat room, a lot of people have been asking about ivermectin. So we're going to get to that. But first, we're going to do a poll. We're going to do a little study here. So Britt's just going to set it up downstairs. You're going to pull out your smartphone, and we're going to get you to text EMRAP to this number, 22333, and then you're going to answer the question. So let's go back to Britt and see if we're ready for this, see if we can make it work.
Okay. Quick switch of everything. Okay, so again, you're going to text the number 22333 and text EMRAP to that number. And the question is, would you prescribe ivermectin for COVID prophylaxis?
So we're going to let that run for a while, and then we'll write down the results, and then we'll get back to that a little bit later. So now what I want to do is show you a very short video. So Brianne Barker is a PhD, a vaccine expert. She will be joining us, if everything works well, in the chat room and the discussion later on. But this is a shortened version of one we've already posted that's already been seen by many thousands, tens of thousands of people. But I put this in here to remind you of what she said and sort of to get the questions going, because I already see a lot of questions. So let's roll the videotape on this one. So the first question I asked Dr. Barker was, do you make mRNA forever, or does it get turned off? How does it get turned off? I don't want to be making this forever, this spike protein.
So you don't make spike protein for the rest of your life. So this actually sort of relates to the question of which cells are making the spike protein. And there are kind of three options of cells that are going to make the spike protein. This is an intramuscular injection. And so some of the cells that are going to make spike protein will be myocytes that get transfected with the mRNA. Mm-hmm. Some will be local dendritic cells. So some local dendritic cells will get that mRNA and then move to the lymph node. And in either case, we're going to see some priming of CD8 T cells, killer T cells. So they will start to make a good immune response. The first time that a CD8 T cell sees its protein antigen on the surface of a cell, that activates the T cell. The second time the T cell sees its antigen, it kills the cell. You're going to see those cells that are producing spike eventually get killed and be cleared by the very immune response that they have induced.
So the next thing we talked about was the Oxford vaccine, the fact that the half dose, full dose was better than full dose. And why did that occur? It occurred by accident, but it turned out that the half dose, full dose was better. Why?
Part of it is actually related to something else that you've mentioned. So this is a monkey virus that they're using. It's called chimpanzee adeno. And the reason why they're using that virus is that adenoviruses are known to be really good at delivering nucleic acid, but they have this problem that many people have already been infected with them. And your body makes a really strong immune response, which can destroy the vaccine before it has time to induce an anti-spike response. So they used a chimpanzee virus to get around this and to hope that people hadn't previously been infected with this virus. What we think happened is when they went high dose, the first administration led to such a strong adenovirus response that the second vaccine administration actually got blunted by the immune system trying to clear the adenovirus. There wasn't enough time to make a spike-specific response to the second dose. And that's been seen in some other types of adenovirus studies. There are some other immunological hypotheses that people have been arguing about that could be going on here, but the immunity to the vector is the thing that most people think happened here.
Okay, then we talked about mRNA vaccines, and specifically the idea that because the lipid nanoparticles and the mRNA themselves do not produce antibodies, that you can give these multiple times, unlike the virus vector ones like the monkey ones. Is that correct?
Exactly. We make a little bit of an inflammatory response to the mRNA and to the lipid, but we don't make an antibody or a T cell response. And so you can give an mRNA vaccine again and again. And if there was some new pathogen in the future, you could get an mRNA vaccine and be fine. If there was some new pathogen in the future, you couldn't get the monkey adenovirus vaccine if you had previously received monkey adenovirus COVID vaccines, because you'd make such a strong response to the vector.
The next question I ask, I think, is really important. What if you get the Moderna vaccine now and then the Pfizer vaccine in 3 or 4 weeks, or Pfizer and then Moderna? Would that work? Because maybe I'm going to forget which one I had, or maybe they're going to run out of one of them. So can you mix and match your mRNA vaccines for COVID-19?
So actually, it's a really important question, and we don't know the answer to it yet. They are not currently doing those experiments in patients to check on that. But you could imagine when someone is actually going to get the vaccine, they may not, if they are not a This Week in Virology aficionado, they may not pay attention to which version of the vaccine they get. And they may come back 3 weeks later and the pharmacist may ask them, do you need the Moderna second shot or the Pfizer second shot? And they may not know. And so this is entirely likely to happen to a number of people. In my sort of immunologist reading of this, or as an immunologist, I think the Moderna and the Pfizer would probably be fine because they're using the same antigen. And so it should work, but no one has officially done that experiment.
That makes sense. So make sure you write down when you go get your vaccine, which one you got. That's
yes.
Good. Right on the back of your head.
From everything that has been published so far and shown so far, it would be safe for them to get the response. And the response that is coming from the vaccine is likely to be pretty superior to the response to natural infection. With the vaccine, we're largely only using the spike protein and not any of the other proteins from the virus. Some of those other viral proteins seem to mess with the immune system. And so there's some pretty great studies that have come out showing some defects that are happening in immune responses in natural infection, which might affect longevity. The vaccine shouldn't have that problem. The other thing that is actually quite important to realize is that the outcomes that they have been looking at in these trials have been symptomatic infection. They have not been doing nasal swabs throughout this post-vaccine period to look to see if people have been infected. They're taking a lot of blood samples. And so there are things that they can take a look at later on, say responses to viral proteins other than spike, that can tell them about infection. But right now, all of the data we're seeing are preventing symptoms, not preventing infection. And so that may have some implications for what we see in terms of transmission at the population level.
Right, very important point. We don't know whether you can still get a mild syndrome and pass it on to grandma and grandpa that hasn't had it.
Exactly. And until we know that, we may still be wearing our masks for a bit.
Masks. Okay, we're getting through lots of great questions here in the chat room, and this is exciting stuff. But let's talk about therapeutics with the 3 S's. I've just realized. Sean, Stuart, and Swami. Therapeutics.
Alrighty, Sean. So we have quite a bit to get through, actually, more than we thought since the last time we spoke. And let's do this like we have in the past. Let's start talking about the drugs. And then after that, we'll move into the plasma and the antibody treatments, and then finally to the vaccines. Without further ado, let's get into some of the drugs.
Yeah, so this WHO or WHO Solidarity Trial, we talked about this, if people remember when we first started talking about remdesivir, and we mentioned this large trials that they're doing. Well, this is the same data, but now it's expanded to other drugs. But these are massive numbers, 405 hospitals, 30 countries, 11,000 patients. But these patients or subjects were randomized to 4 different treatment arms. So remdesivir, hydroxychloroquine, lopinavir, and lopinavir with interferon beta, or no treatment. And what they showed, and it's pretty disappointing to say, but there was no clinically significant benefit, no benefit on mortality, no benefit from decreased ventilation, and no decreased hospital stay. So unfortunately, for all the drugs that we just mentioned, doesn't look so hot based on this data.
Yeah, we should have listened to Jerry Hoffman in the beginning when he said that, you'll get a lot of positive signal. Basically, that you'll get a lot of positive signals. But in the end of the day, when the history is written on this stuff, we're not going to be talking about remdesivir as the miracle treatment. And for that matter, tocilizumab. And here's another one. This also is of import, right, Sean? The New England Journal study on tocilizumab.
It is. So just to briefly remind everybody, the tocilizumab is an IL-6 receptor antagonist with the thinking of maybe we could blunt that cytokine storm. So this is out of Boston, 7 hospitals, and everybody we're talking about is confirmed COVID and clinical criteria and all the studies that we mentioned. But it was randomized, double-blinded, placebo-controlled, and they got a single dose of tocilizumab. Some received remdesivir, but none of them received dexamethasone. And the reason why that is because just the timing of the study. And what they showed was there was really no change in days of supplemental oxygen, no change in ICU admissions, no mortality benefit. What is good about this study and the next study we're going to mention is a large number of Hispanic patients were included. And of course, people of color are being hit harder by COVID. But there was about 40% of the subjects in this study were Hispanic, but unfortunately, tocilizumab doesn't seem to be too effective.
Okay, so as you said, the next study also is of import, and this one has a little bit more of a positive spin. It's hard for me to believe, because I am still so skeptical about remdesivir, Sean, that this has a lot to do with it. But this is a positive study, right? It's not huge, but it's positive, right?
Yeah, and I share your concerns or reservations about remdesivir, absolutely. But baricitinib is a JAK inhibitor, and JAK inhibitors work upstream from. So what they do is they decrease not just IL-6, but IL-2, IL-10, interferon. And that way you block all of these. And again, with the thinking of maybe decreasing that cytokine storm, this is part of what's called the ACT protocol, which is from the National Institute of Allergy and Infectious Disease. And this was randomized, double-blinded controls trial, 8 countries, 67 different sites. And they got standard dose of remdesivir. So that's 200 milligrams in the first dose and then 100 milligrams IV up to 10 days. And then they got baricitinib orally for 14 days. It was a good size trial. There's about 500 in each arm. Over 50% of the patients were Hispanic. So again, good to see. And what they really showed in a benefit was decreased days of high flow or supplemental oxygen. So it's 10 days versus 18 days, and a mortality benefit at 28 days of 5% versus 8%. However, there was no difference in the need for mechanical ventilation or ECMO. But the adverse events, because remember, these JAK inhibitors, we were worried that maybe they'd cause increased infection just because they work so upstream. There doesn't seem to be any increased infection or adverse events really from baricitinib. But again, positive, but I think we just have to be a little cautious how to interpret this.
All right. So let's talk a little bit about steroids. Just quickly, another very positive study, sorry, just coming up here, in JAMA. Not a whole lot of new information here. And I think they stopped this one, right? When the British study results came out, right?
That's absolutely right. So this is out of Brazil, 41 different ICUs. And what they did is they used dexamethasone, but they used a higher dose. They used 20 milligrams IV for the first 5 days and then 10 milligrams for the second 5 days, where recovery, the study that you just referred to, used 6 milligrams for 10 days. But this was ended. It only had about 100 patients in each arm. There was no difference in mortality, but did show a benefit in ventilator-free days. And that might be beneficial when we're looking at resource allocation. But this was stopped early, as you said, because of the recovery trial. And I think everybody is.
I jumped the gun here a bit, but one of the concerns that we had about the steroids, as we saw that they're beneficial, is that they might actually delay viral clearance. That's one of the sort of ongoing things that was bugging us. And we actually have a little bit of data on this. This is interesting, out of Nature.
That's absolutely right. So this is interesting because that was a concern, and we talked about it ourselves, because looking at some other viral illnesses, particularly influenza, it's shown if you give steroids, there's decreased viral clearing, and that could be a bad thing. So this was very small numbers, 59 patients treated with steroids, most of them methylprednisolone, just to point that out, about 75% of them. But what is the good news is viral clearance was not affected by steroids. But if you were over 70 years of age or had more severe disease, you had decreased viral clearance, and that was independent of steroid use. So that might be why we're seeing such a high mortality in those sicker patients and also those patients who are older.
This is interesting. And so this is actually the Argentine data. I'm not 100% sure if this is the same stuff, the same data that we talked about last month, but unfortunately, this didn't work out so well, even with high titers.
So this is a double-blind, randomized, placebo-controlled trial out of Argentina. There was adults who had COVID, but also pneumonia, and they were randomized to get either this convalescent serum or not, and they gave a good volume, so it was 500 mils with titers at least 1 to 800 and as high as 1 to 3,200. So that's really in the range that we were thinking that they needed to be. But unfortunately, at 30 days, no mortality difference, 10% and 11%, no difference in clinical status at 7 days and 14 days, no difference in hospital discharge. So unfortunately, I just don't think convalescent plasma is working out as well as we would hope that it would.
So here, the question is, Sean, why do you think that might be?
You know, this has really been bugging me, and I've been thinking a lot about it. And I think the reason is if we look at the monoclonal antibodies and if we're looking down at the vaccines, these are very targeted, particularly towards that spike protein, where this is just kind of a mixture of whatever you get out of someone's body. And I just don't think that maybe it's targeted enough to do the benefit. I just don't know, but it is disappointing.
I like the way that you put that. This is targeted to whatever comes out of a person's body. That gives people a little too much leeway, I think, Sean. So talking about monoclonal antibodies, I think that these are something that, I mean, we don't really have quite the data to show it, but it seems like they may be working. They probably are working. And I figure that if I can pronounce these things, that if I do that alone, I won't have to say anything else intelligent because that'll be good enough, right? So let me try it. Okay, so the Regeneron product that we've seen some famous people get is casirivimab and imdevimab. All right, and so those are the two antibodies. And then the other product that you're hearing a lot about from Eli Lilly is bamlanivimab.
Excellent.
How'd I do?
Fantastic. I'm quite impressed. Better than me.
So anyway, let me get to the COVID treatment guidelines from the NIH for these two drugs. And basically, you'll notice that although there's two boxes here, that they are identical. They just separated by 12 days, basically. And so they both have an emergency use authorization, both these products. They've got the same indications, these high risk of progressing to severe disease and hospitalization criteria. Not for patients less sick than that or for outpatients, and not the standard of care. This is the same identical guidance on both.
Absolutely. The only difference is the Regeneron product has 2 monoclonal antibodies where the Lilly product has 1.
And this is the paper. I'm just going to bring this up here.
So this is a study out of the New England Journal of Medicine. This is the Eli Lilly product. And this is a phase 2 trial, which is really, this is almost a dose finding study that they were doing. So they had patients that were randomized to get either 700 milligrams, 2,800 milligrams, or 7,000 milligrams as a single dose. And what they found is that the greatest decrease in viral load was at this 2,800 milligram dose at days 2 to 5 to 6. And hospitalizations or ED visits were decreased in the group that got monoclonal antibodies about 2% versus 6%. So early prelim data, but it seems like the monoclonal antibodies of everything we're talking about is probably some of the more promising therapeutics that are available currently.
So these are the 4 vaccines that we talked about last month. And at that time, they were all in phase 3 trials. And boy, what difference a month makes. Now, of course, the Pfizer vaccine is approved and being administered. Moderna is in the approval process this week. The AstraZeneca Oxford trial, maybe the efficacy wasn't quite as good as the mRNA vaccines, but they've already published their phase 3 results in the Lancet, very transparent. And the Johnson & Johnson trial, that was, remember the one with the single jab, also adenovirus, that is reaching the completions of the phase 3 trials. And so that's all happening. I think one of the important things that we did want to communicate about was the allergic reactions that were reported with the first administrations of the Pfizer vaccine. Do you want to speak to that, Sean? Because that's something I think people are concerned about.
Yeah, so I think most probably heard about it, but this is being given to patients as well as healthcare workers. So there was 2 healthcare workers who have a known history of severe allergic disease, so much that they carried EpiPens with them, and they got severe allergic reactions to this. Now, it's interesting because there's no egg product or other things that we can identify, but it's probably these are just people who have bad allergic reactions to lots of things and got this foreign material and had it. As a result, though, now the way it's being administered is people are being watched for 15 or even 30 minutes after it. So that's going to slow down the throughput. And if you have a history of severe allergic reaction, at least the current recommendation is maybe you shouldn't get it until we have a little bit more data.
One vaccine that we didn't talk about last time, the Novavax vaccine, is also in phase 3. And this has a different mechanism. Again, this matrix M1 adjuvant recombinant SARS-CoV nanoparticle vaccine. There, I said it. I understand, though, that technology is the same that we use in the varicella-zoster vaccine and the HPV vaccine, right? But the big thing here, from what I understand, is that this doesn't cost as much to make, doesn't require the deep freeze. And so when it comes online, it might be one of the big global solutions when transport and all those things are considered, right?
That's absolutely true. Though we want to include this one because it's moving along. It's ramping up to this phase 3 trial, and they're expecting hopefully in early spring to have all their data in. So this is one I think that for all those reasons that you'd mentioned that we're going to hear about. I know there's a lot of concern from the public and even some healthcare workers. Which one should they get? You know, Gertrude Stein said, a rose is a rose is a rose. For me, a vaccine is a vaccine is a vaccine. Just get whichever one becomes most available to you. We don't know if it's going to be distributed geographically, but this is, as you mentioned, standard previous technology that's used that's been shown to be effective in a lot of different types of viruses.
Okay, just to round things out, Sean, each time we do this, we try to bring up something new, something that people are asking us about. And vitamin D is that thing this week or this month. And we have a couple of articles on it, and they're small, but people are asking us about this. So what do we have to say about vitamin D, Sean?
So we do. We hear in the YouTube chat and people shoot emails and things like that. So why might it be beneficial? Well, it activates this vitamin D receptor that may decrease that cytokine and chemokine storm that we hear about, but also it modulates neutrophil activity in a beneficial way. It's thought to maintain the pulmonary epithelium, decreases coagulopathy, causes epithelial repair. And any of the internists that you work with or maybe listening, internists have been real hot about vitamin D for 10 years or more. So these are 2 studies. One was a clinical trial where they gave fairly high dose vitamin D to ICU patients or anybody really who had COVID. And then the other one just follows levels. And the one that followed levels showed that if you were vitamin D deficient by their serum 25-hydroxy vitamin D level, they showed that there actually was increased mortality with that. And that was predominantly in patients who had chronic lung disease, coronary artery disease, and diabetes mellitus. So look, this is not robust data. we're just throwing it out there because people have asked, but maybe as more data comes out, maybe along the lines of recovery trial type data, maybe we'll see that vitamin D might have a role.
All right, so that rounds it out. It's an exciting month, hopefully the beginning of the end. Thanks so much, Sean.
Thank you too, Stuart.
Now, just as an addendum, and we have Swami, want to bring Swami into the conversation. A lot of people are like, there's certain things it seems like you gloss over. There's no new data or not much going on. And we get some responses like, well, what are you talking about? Wait a minute. There's this, there's that, there's the other thing. So I wanted to give Sean actually an opportunity to weigh in a little bit about, how we select what meets the conversation grade for these papers.
Well, thank you, Stuart. And for everybody listening, thanks for being with us. We appreciate it. And if you've been with us from the beginning, you've seen from the beginning, we're doing these pre-published and not peer-reviewed, but we think there's enough data out there that we're being very selective. So you see everything pretty much we did tonight was a randomized controlled trial. If you do searches, you will see every agent we're talking about, there's data out there, but we're really trying to be selective with the best data as we see it. And that way we can provide the best information.
Right, and so with ivermectin, for example, I want to actually make a shout out to John Kelsey, who's one of my seniors who asked about it. And a lot of people are asking about it. We just mentioned that there wasn't anything to present. It has been since, I think, June, right? Since Sean and I talked about it. But just for good measure, Swami's done a deep dive, and he just wants to give us a little bit of summary of that. The ivermectin, what's your summary on the ivermectin? People want to know.
I definitely wasted a couple hours of my life reading this data, put that in quotation marks. So what do we know about ivermectin? It's an antiparasitic that works really well for scabies. That's what we know. It seems to be pretty safe and pretty cheap, but we don't really know if it works here, right? So we've got some in vitro data that shows that it kills it, but we, put enough alcohol in there or bleach in there, it's going to kill COVID too. So that's not really a good indication to use the drug. We've got some observational data, which is pretty low quality. There's a couple of RCTs, but they're non-blinded, and the endpoints are kind of soft. So Stuart, you know this. You can fudge endpoints if you know what's being studied, and that's kind of how these studies look. So right now, ivermectin, we don't have any good quality human data to tell us to use it. What we need is a good, high-quality study. Ivermectin might be the drug that helps with prophylaxis. It might help with treatment, and it's super cheap, easy to get. And one of the big things is it's easy to get in developing countries, which is really critically important because some of these meds that are coming out are super expensive. You guys talked about them already. So we need a good, high-quality study. So people should be getting ivermectin in the setting of a well-designed randomized control trial so we can get real answers and we don't end up in the rigmarole of 9 months of hydroxychloroquine that we've been going through or convalescent plasma.
And as we mentioned, that is happening. So, and we will report on that when it happens. So, and then the other thing quickly, Swami, is, and I kind of feel guilty about this, the monoclonal antibodies, there's this huge assumption that these things are working. And it really is, I think, on the basis, to be honest, of some psychology. We're seeing all these older, massive people go in to the hospital when they start getting symptomatic, and then suddenly, like a day later, they seem to be fine, and it's like, oh, it must be working, but there really isn't the data. And I want to let you weigh in that on that as well.
I'm pretty sure that I could talk about this for hours. I won't. I'll try to do 30 seconds, but we don't have great data on these. So the two that people talk about are the bamlanivimab, BAM. We got that one. That's the Eli Lilly product, and then we got the Regeneron product, which is 2 monoclonal antibodies. The Regeneron product, none of the data is released. We have the FDA interpretation of the data, and it looks suspect, but we need to read it. We need to read that data. Now for BAM, we have the article published in New England Journal of Medicine, and here's the tricky part about the study. The study had 3 primary endpoints. They only reported one of them. And actually, Stuart, here's where it gets even more complicated. 3 primary endpoints with 3 different doses of drug. That's actually 9 primary endpoints. Now, Stuart, I know there are words that you know that I don't know. We both know what the word primary means, though. Primary means 1. They didn't have 1, they had 9. So 9 primary endpoints.
I know what it means, Swami. I know what it means. It means you have to do a Bonferroni correction or something like that, because you can't.
I do not think that word means what you think it means. So 9 primary endpoints. One of them was statistically significant. But here's the thing. It was statistically significant, but didn't meet their pre-specified outcome. So it actually didn't show anything. They didn't show any benefit of that drug, but it was really spun very positive. So people like it, and it's being given quite a bit. There are infusion clinics set up just to give this drug to outpatients. And one of the things that people are touting is that it reduces hospitalizations, but that was a secondary endpoint that's hypothesis generating only for a drug that's expensive, that we are setting up infusion clinics for, that people are referring patients to the ED just to get and be discharged. We need a lot better evidence than that.
All right, then let's go to Brit and we will do another poll. Lots of discussion still going on here, and let's do another poll and ask the same question again. You ready, Brit?
After that discussion, there's only going to be A, B, and C here, not D. Let's see how we feel about ivermectin at this point. So previously, the vast majority, 74% of people said that they have no idea if they would be giving ivermectin or not. 20% said no, that there's not sufficient evidence, but most of us were just kind of on the fence, not quite clear. We'll let a couple of these come in.
So we want to see if Swami's little spiel there changed anybody's mind. And I'm betting that it changes nobody's mind.
Did it sway anyone? Ivermectin yes, ivermectin no.
So, you know, the original ivermectin studies were done in tissue cultures, as Swami said, and they were done at doses or at concentrations which would basically be lethal to you if you tried to take enough tablets to get that tissue concentration. So just understand that's the level of a lot of this data. We just have to wait for it. So it actually looks like Swami actually did sway a few people here. We'll get back at the end and give you the final results.
If you could see him in the Zoom, he's cheering for the no. He's literally cheering for the no. And
it's highly scientific.
Yeah, this is high science you're watching.
I think he swayed a few people. We'll keep this open for a second.
This is as good as the available data.
Let's now talk about anticoagulants. I did a couple of shifts in the last week or two. I was in there with Greg Moran last week, and this kept coming up. Like, should we anticoagulate this patient, and how much should we anticoagulate this patient? So Swami's going to give us a summary of this puppy.
All throughout the COVID-19 pandemic, one of the really hot topics we have been discussing and debating is the use of anticoagulants and prophylactic anticoagulants. We know that COVID-19 is a disease where people get clotty. We've got some observational retrospective studies showing that, and those same studies tell us that patients who are started on prophylactic anticoagulation are less likely to die, they are less likely to deteriorate. Now, these aren't the best quality evidence. They're retrospective observational. We don't really have RCTs to guide us. But those studies are coming. Active 4 is looking at both inpatients and outpatients and starting those patients on prophylactic medicines. But while we wait for that, we need to do something with the patient in front of us. So we know they're more clotty. What do we give them? How much do we give them? Do we give it to the outpatients? So many questions around this. When we look at the CorePendium chapter, it does give us some information on this. The CHEST guidelines tell us that if you're admitting the patient, they should be on some kind of prophylaxis. I think we knew that already, but it doesn't really give us any guidance on what level of prophylaxis to give people, how much we should be giving, and what to do with those outpatients. And this has really fallen in the lap of the emergency physician because we're managing these patients longer and longer in the department. So we need to really be on top of this. One of the things that we're going to talk about throughout these recommendations are D-dimers, and we're not using those dimers to determine whether they have a PE or not, whether they need advanced imaging, but it's part of many of our COVID algorithms is to get a dimer. Again, we have studies showing that patients with markedly elevated dimers are an increased risk for death, they're an increased risk for deterioration, and we're using that as a marker to determine who needs what level of therapy. And what I'm going to share with you guys really is expert opinion, is what we're seeing across the board in many different places, but there's really no consensus. And we need those good randomized control trials to get there. But let's see what we're doing right now. Let's start with a little bit of the spectrum of disease, starting with the patient who is in your emergency department. They have COVID-19 or presumed COVID-19, but they're not hypoxemic and they are going to be going home. For those patients, I'm mostly sending them home with no anticoagulation. And I think that's what most people are doing. Some people are giving them an aspirin. Again, we have randomized control trials that are going to be looking at whether we should send those patients home with anticoagulation, but we don't really have anything telling us to do that now. So I probably wouldn't send that group home with it. Now, the other patient we have who we're sending home is the one who has a history of an unprovoked PE or DVT in the past. Those patients are at a higher risk. They've had an unprovoked clot before. Now they have a disease that makes them clotty. For those patients, I probably would discharge them home with some prophylaxis, either low molecular weight heparin sub-Q or one of the direct oral anticoagulants. And I would try to do that in conjunction with the patient's primary care doctor. And then the final group that we're sending home are those that are slightly hypoxemic, But a couple liters of nasal cannula, we get them up. We have a home O2 protocol. So we're going to send them home with a tank of oxygen. Normally we'd be admitting those patients. So I think it's reasonable to consider VTE prophylaxis for that group. And I'd probably give them the prophylaxis dose. So again, low molecular weight heparin, probably in the 0.5 mg per kg per day subcutaneous dose, or you can give them 40 milligrams sub-Q times 1 per day. Either one of those is a good plan, or you could do it with a direct oral anticoagulant, but most people seem to be favoring low molecular weight heparin at this time. Those are your outpatients. Then we got the second group. These are patients who are hypoxemic, on supplemental O2. We're admitting them to the hospital. All of them need prophylactic medications for anticoagulation. And I think the general approach here is low molecular weight heparin, either in the 40 milligrams once a day dosing sub-Q or the 0.5 mg per kg per day dose. We're typically using enoxaparin in my shop. So enoxaparin 0.5 mg per kg once a day sub-Q seems to be a good approach in that group. Now, within that hospitalized group that's going to the floor, there is a little bit of variation. So some people are looking at dimers and saying, well, if the dimer is markedly elevated, we're talking about 6 times the upper limit of normal. Those are patients who are maybe at a higher risk that I'm admitting. And so if I'm admitting that patient, they have a markedly elevated dimer, maybe I should give them therapeutic dosing anticoagulation. And I think this is really going to depend on your local flavor. And then going back to that patient we had before who's going home with home O2 to determine what they need as far as anticoagulation, another thing you could do to risk stratify them is to get a dimer. And if that dimer, again, is 6 times the upper limit of normal, that might push you towards giving them that prophylactic dose. So for the one going home, maybe prophylactic dose with the dimer markedly elevated. For the one you're admitting, some people are looking at that dimer and saying if it's 6 times the upper limit of normal, we're talking about 3,000. If your cutoff is usually 500, in that group, maybe giving them therapeutic dosing, but we're not sure if that's the right approach or not. And it's really going to depend on what your hospital is doing. I would probably find out what the inpatient side is doing before you make that decision on your own. Now, finally, we have the really sick subset, the ICU players. And we do have some data showing that those patients are heparin resistant. They have some kind of a weird heparin resistance, which makes them clot even with prophylactic dosing. Josh Farkas has a fantastic post on PulmCrit looking at that topic. You can check that out for more details. But this means maybe for the ICU players, we need to go with a higher dose. And a lot of experts are saying, we're not going to go with the prophylactic dose for those patients. We're going to go with therapeutic dosing. So for low molecular weight heparin, we're talking about 1 mg per kg once a day. Instead of what we were talking about before, the prophylactic dosing at 0.5 mg per kg, we're escalating that 1 mg per kg once a day. That's going to be fine for patients who have intact renal function. But we also know that COVID-19 messes with kidneys. So if the patient has an AKI, if they have an elevated creatinine, then you're going to want to think about using unfractionated heparin instead, adjusting it based on your PTT. Typical dosing, 80 units per kilo as a bolus, 18 units per kilo per hour. And then there's some other nuances that our ICU colleagues are doing. They might be looking at TEGs and anti-10A in order to adjust these. I don't think we're going to be doing that in the emergency department. Most departments don't have TEG available. I would leave that up to your intensivist. Talk to your intensivist about that. But for the ICU players, I would consider giving the therapeutic dosing of these agents. And again, typically low molecular weight heparin, enoxaparin, 1 mg per kg sub-Q once a day, or going with unfractionated heparin at your typical dosing. And I think that's basically right now what we are doing in terms of thromboprophylaxis, in terms of these thromboembolic events, both arterial and venous. And we're going to have to see what the literature turns up over the next couple of months and see whether that shifts.
All right, there's a ton of questions and we're going to get to them. We're going to have a question and answer period at the end with all of our experts. But now we have to get into the sort of the more difficult conversations here. I'm just sort of overwhelmed about how many cases there are. You hear from Swami, when they had their first surge and stuff last night, just being for like 4 hours there with Britt, just so many patients coming in. And although most of them go home, that subset that stays and there's a subset that goes upstairs. And to hear the codes upstairs, I've never heard anything like that in my career. Just how many arrests and codes are being called upstairs. It's really quite bad. If the curves continue here in Los Angeles, we are going to have to move to crisis standards of care very quickly. Annette Decker is a fellow at UCLA, and she's going to explain to us very quickly what that means, and then we're going to talk about palliative care.
So I'm Annette Decker. I am a ER physician. I'm currently doing a research fellowship that's focusing on health equity at UCLA.
I've heard this term crisis standard of care. I don't know what it means, and Dave Schroeder says you do. So can you explain what a crisis standard of care is?
Yeah, Mel. So a crisis standard of care is really an operational plan that's enacted by a healthcare system when there just aren't enough resources to do our normal standard of care. So examples of when this might happen would be an example of a catastrophic event, so like a hurricane or an earthquake, or alternatively, a more pervasive change, such as a pandemic, such as COVID-19.
So who sets them? Does the state set them? Does a hospital set them? Does the ER set them? Who does this setting?
Yeah, so they're generally made on a state level, and it's a pretty diverse committee that comes together to decide what these guidelines will be. Generally, it includes providers, medical ethicists, public health experts, and then again, local and state government officials.
And are there legal protections that go with this? So let's say the state comes along and say, okay, you don't have to intubate all the 95-year-olds who have COPD and other medical conditions. You can now only think about doing that to 85-year-olds. That's, sort of a random example. So are there legal protections, or can people come back later and say, oh, I don't care about there was a pandemic last year? You should have done more.
On face value, none of the protocols that I have read through explicitly protect physicians. I think to get explicit protection, you would really need the governor to make a declaration of immunity, which has happened in a few states. That being said, when we move to crisis standards of care, there really is a general understanding that we're no longer operating in our standard of care protocol. We're really moving to this adjusted protocol in this crisis time. So I'm not a lawyer, but I would imagine that it would be hard pressed to find a case against a physician if they were operating within these guidelines.
Yeah, it seems that would be difficult if everybody in the community is basically doing the same thing, to say that you practiced outside the standard of care, because the standard of care is what everybody in the community would generally do.
Exactly.
So what do these actually, do you think, would look like? California, if some of the modeling is correct, is going to be completely overwhelmed. We are not going to be able to intubate lots and lots of people and do what we are currently doing today. Do you have any sense of what some of these might look like?
Yeah, so for us as ER physicians, the question of triage is really going to be about critical care, whether that is access to an ICU bed or a ventilator or ICU personnel or potentially even oxygen. So on a practical level, what would happen is that your hospital would set up a triage committee or a triage team. So you as an individual physician wouldn't necessarily be making those decisions yourself. And in most of these crisis standards of care, the decision of how and kind of who and what gets triaged is based on an algorithm. In most of them, the algorithm that is used is the SOFA score, or the sequential organ failure assessment score. And so you as a physician would potentially send the objective measures of how your patient is doing to the committee, and the committee would then decide who gets the ICU bed, who gets the ventilator. Oftentimes the cutoff on this that I'm seeing is like a SOFA score greater than 11 potentially would exclude you from getting those resources. The one thing I would note, Mel, is that this applies not just to patients who have COVID-19, but to anyone coming into your ER. So if you have someone that's a trauma or a head bleed, you would also be applying these triage criteria just as the patient that you're thinking about intubating because of respiratory distress.
Well, now I understand that, and there's a much longer part of that video about, legal protections and about communities of color, and that should be posted tonight or tomorrow. Now let's talk about what this really means, how we actually would implement this in the emergency departments or on the floor if you're called up to start working on the floors. So we've got Vanessa Carty and Ashley Shreves, who are our palliative care experts. They're going to take us through the nitty-gritty of this.
Yeah, so I am a full-time emergency and palliative care physician at Ochsner Medical Center in New Orleans. I do about 6 weeks a year on the inpatient palliative care service. And I trained in New York. I did a fellowship in palliative care at Mount Sinai after doing an emergency medicine residency at St. Luke's Roosevelt. Well, I think that one thing that I feel very fortunate about is, in the spring, our strategy was, you got put on oxygen if you needed more than 6 liters, nasal cannula, you got intubated. And so I think what that meant at the bedside is that goals of care discussions happened rapidly. They were pressured. There was a lot of a lot of need to do this quickly. And there's always the worry and the concern if things are done quickly, maybe the quality is sacrificed a little bit. And so I certainly, I think many of us had worries about that. And I think one of the dramatic differences now in this current surge is that, we have all of these tools. We have non-invasive ventilation, we have high flow nasal cannula, and we will really push patients, to the brink on these therapies before going down the road of mechanical ventilation. And what that means is that these conversations now, I think, can happen much more slowly, much more organically, in a stepwise fashion. I saw a patient 3 weeks ago when I was on the palliative care service who, I saw him the first day in the ICU when he was on 80% FiO2 BiPAP. And he said, am I going to die here? And I said, I think I'm worried that you could. And then we had to spend that day just kind of absorbing that, like he might die. And he's like, I need a priest and I need my last rites and I need, or anointing of the sick. I need my final confession. Let's appoint a healthcare power of attorney. And then the next day I came in and we talked about, what kind of things he may or may not want if things got worse. And then the next day I came in and we made some decisions. And then on the 5th day, he got intubated, and I felt like I have a lot of confidence then, in the process and what ultimately was decided, because we had a lot of time to be thoughtful and deliberate about that. And so I think that's a very big difference now versus in the spring when everything was just, happening too quickly, out of necessity. I think no one did anything wrong. It's just that's how it played out then. I think that's one of the big differences. And you mentioned the families. We really pushed our institution in the early fall to allow family members to come in for COVID patients, because we just saw, it's just like, you have to have the family there. They cannot make decisions for their loved ones without being present at the bedside every day. I don't think the patients can recover without their family members being there. And so we pushed, and to our institution's credit, they actually now allow even the COVID patients to have a visitor every day. And so that's been a big shift, to be able to have family members there. It changes the whole dynamic, establishes trust in a different way, and I think allows for healing in patients that are going to recover in a different way. So we have one visitor per day right now, except when patients are, truly at the end of life, and then the whole immediate family can come in. We have been fortunate because we've really not, except for the very, very beginning, had a significant PPE shortage at our institution. They've been, I don't know how, secured a large amount of PPE from the very beginning. So we have adequate supplies of PPE. So the whole family is, they have everything. They get the gown, the N95. And I think the reality is, and this was something that we had to sort of acknowledge, is many of these patients, especially the ones that are dying, are often 3 or 4 weeks into their stay. And they're often 5 or 6 weeks into their illness. So the reality is most of them are not infectious or contagious at this point. I mean, we're still giving the families full PPE, but I think the fallout that everyone was worried about, that there were going to be all these infections, and that was the reason this never come to fruition. I mean, we've never really seen that. And this policy, again, we've been doing this probably a couple of months now. And so I think it's safe. The reality is most people, they have their spouse coming in every day, that same person. A lot of those family members have already had COVID, right? And so it's actually worked out just fine. The one thing to emphasize is that the key feature of this disease at the end of life is, severe dyspnea. And so obviously that's a feature of a lot of cancers, lung cancer, a lot of cancers, and other illnesses. So it's not unique in that way, other than it's probably on the more significant and profound side. So whereas a lot of patients are going to need opiates at the end of life to palliate their dyspnea, these patients are going to need a lot of opiates at the end of life to palliate their dyspnea. And so whereas in some patients, you might be like, oh yeah, I'll just order a PRN, morphine, give them a 1 milligram push to start. And then if that doesn't work, I think for these patients, I'm generally just going straight to a morphine infusion. Whereas I maybe wouldn't do that with all patients at the end of life. For these patients, I'm starting with at least 1 milligram of morphine an hour, and then often rapidly titrating up from there. And I think one of the additional advantages is, particularly for the hospitalized patients, the nurses are because I think of still the fear and concerns about exposure, not wanting to go into the room every 2 seconds to adjust that. So if I just put them on an infusion, I know they're going to get what they need and it can be rapidly titrated. And so that's, I think, the only difference is I'm probably more likely to just go there right off the bat. And I'm glad you pointed out. I mean, I think the reality is that very few patients that are coming in and going straight to like a comfort focused plan. That might have been the case in the spring because it was like 6 liters or intubation, make a decision. And so I think we were very rapidly making those transitions. And I think now we're very rarely making those transitions early on. I think most people that are coming into the hospital would like a trial of some sort of therapy in the hopes of improving. And so they are often making these transitions after a trial of high flow or a trial of non-invasive ventilation. It's rarely in the emergency department setting. It's often days or weeks into their stay. And so you're sort of titrating down these things and titrating up the palliative medications. And then the other group, that I'm involved with are the patients that are having a full withdrawal after a trial of aggressive critical care. Those patients are so sick, in my experience, when those treatments are stopped, they're dying in minutes. And really not even needing a whole lot of symptom management at the end of life. One is, what do you do when you're truly in a situation where you don't have the resources? And so someone's not going to get, access to critical care or a ventilator because there's not the resources. And I think in that situation, I would refer everybody to Vital Talk, which is a terrific online resource. It's more than an online resource, but this group has put together actual scripting and talking points about language that could be used in that specific scenario where you are enacting crisis standards of care and you're going to be allocating resources and rationing. So the language is, for instance, they say, in response to that, the person, grandma not getting an event, these are extraordinary times. A year ago, we would be making different decisions. But this is where we are right now, and we're trying to be fair. They have language like that. So I would encourage people to go to their website. All of the resources are free around COVID scripting and particularly relevant to that situation. I think, though, as dramatic and scary as that situation is, it's way less likely than the more common scenario that I find myself in, and I'm sure all of you find yourself in right now, which is you're looking at a 70-year-old or a 75-year-old who was in okay health, a week ago, and maybe has diabetes and hypertension, and now they're getting worse, and the family's looking to you and saying, should she get intubated? Should I get intubated? And I think that I'm struggling probably as much as all of you because there's really not good data, I think, right now to guide us when it comes to that specific question. There's some data from the spring, but I don't necessarily trust that data for where we are now because the management was different. We had a lot of surprising extubations in the spring of like an 88-year-old who got extubated, and multiple 70-something-year-olds, but they were intubated after just needing 6 liters of oxygen. So that's very different than the 88-year-old who I would intubate today, who would have failed a week of high-flow nasal cannula and non-invasive ventilation. That's a much sicker patient. And so I don't know what to do with the cohorts from the spring, if they apply to the patients I'm seeing now. I'm sort of scratching my head about that. One strategy that I think helps when we're dealing with the amount of uncertainty that we have when we're guiding patients and families is the sort of hoping for the best and planning for the worst, and giving people best case and worst case scenarios, I think is a little bit more honest in this situation than projecting certainty when I don't still have certainty for a lot of these patients. When I was in the ICU a few weeks ago doing palliative care, I asked a wife of a patient who had, really bad COVID. He had 2 weeks into an intubation, 2 weeks into mechanical ventilation, and he had severe illness before he was even, diagnosed with COVID. He wasn't doing well. And I asked her, what have the doctors told you about what's going on and what to expect? And she said, oh, well, the ICU team told me that this is a marathon, And I accept that. And I am in the mindset of we are running a marathon and we're okay with that. And I reflected on that. I was like, why? That just doesn't fit. Like, why is that not working? And I was like, right. The reason that doesn't work is because if we give that analogy, it implies that there's going to be this long, arduous journey. And then at the end, there's going to be this incredible triumph, right? And that's the best case scenario for COVID critical illness, from my experience in the Pal Care side, is that, the 50 or 60-year-old that has a good shot, it's a marathon. Best case scenario, you're talking about often weeks of intubation, months of rehab, and that's best case scenario. And the worst case scenario, which is the way more likely scenario, is I'm going to ask your husband to run a marathon, and then he's going to die at mile 25. And that is, not necessarily the language I would use with someone, but I think that's actually what I'm seeing when people become critically ill with this disease, and for older patients, I would say. I think it's a no-brainer when a 40 or a 50-year-old comes in who's totally healthy, like, we're going to throw the kitchen sink at them. But the place where I'm really scratching my head right now, and I don't have the answers, and if somebody does, please give them to me, is the 70, 75-year-old who's in pretty good shape. But again, I worry that what they're likely to experience is a long, long critical illness, followed by a long, long rehab course, recovering to some quality of life that may or may not be acceptable, and most of the time not even making it to that. And that's sort of the place where I'm struggling right now. And I don't know what to tell families and patients. When people get to the point of needing the ventilator, they're not doing well. Even in resource unlimited settings, some are doing well, but most are not. Particularly now, because we're not intubating people until they have failed every other modality. And so the patients that are getting intubated are not doing well, generally. So I would say, I would try all those tools. And the important thing is to set expectations, right? Telling patients and families that you're worried, that things might not go well, that they might not make it. But that it's okay to continue to hope that they will. And I have had so many surprises. I had a patient in April, a 93-year-old from a nursing home, but who was still very active. She was actually from an assisted living center, not a nursing home. And we had a long discussion. She was on a non-rebreather, didn't want to be intubated, but wanted to still fight. She was like, I have fight in me, but obviously I'm not going that far. And she stayed on a non-rebreather for a week and then got discharged from the hospital and had a full recovery. So I would say that's an important thing for people to recognize, is that sometimes this disease looks hopeless and it's not. And so I think even when you don't have a ventilator available, even when you don't have all the tools, sometimes just supportive care with oxygen is all some patients are going to need, and they're going to turn around. And that was a lesson that was, we had to learn early on. Of course, with that family, I had the whole family on FaceTime telling her goodbye. They all prayed together. They all told her goodbye. They loved her. And then, she got discharged a week later. So I felt real smart in that situation. That's one of the takeaways, is that you just don't know who's going to recover, who isn't. And I think making sure that people understand that they might die. And so if there are important things, like with this patient in the ICU, he needed to have his spiritual needs met. And when, he had his spiritual need met, and I went in the room the next day, he goes, I'm ready to die. Whatever happens, but all my needs have been met at this point. And so I think that's important. So giving people the information that they need, but, also maintaining or keeping a space for hope, when I think sometimes there really is a reason to be hopeful, even when things often don't look good. And then I think, opiates, I think particularly in smaller doses, even when I think there's a chance for recovery, can be helpful, and using those. And to be honest, I really feel like the only thing that's ever been shown to be helpful medication-wise is dexamethasone, and that's cheap. So if you have oxygen and dexamethasone, you're essentially on the same plane as we are. And I think there's reasons to be hopeful that you can turn many patients around.
Personally, I find that spectacularly helpful because we really are in a crisis here. And if the curves are right, this crisis is, it's still 4 weeks away from the peak or even longer. So we will be doing this kind of stuff and we need to be thinking about it now. So, Annette, I want to go to you and ask, have you heard anything yet? Is the governor, has regions started to talk about this? Surely they should be telling us ahead of time, if we get to this state, we will do Y. Is that happening?
Yeah, so I haven't heard anything about this yet. And I will say, I feel like the longer it takes for us to enact this, the hospitals with less resources are probably suffering a lot more. I'm sure all of you practicing out there are feeling that right now.
Yeah, we've already heard just this evening that one of the county hospitals that a number of people work at is already in crisis. They're asking for more coverage, for more shifts. I mean, it really is, this is cascading incredibly quickly. We also should bring up that a number of the ICU experts have said, because of the different way we treat people now, that we wait and we wait and we wait. And Sarah was saying, she's waiting and sitting on people for days in the 70s and 80s, that after they get intubated, the outcomes are much worse. Not sure what to do with that information, but this really is crisis time, and all of the things that were suggested by Ashley really seem smart, and we should be introducing these soon. Let's go to Swami, because apparently your enoxaparin dosing was a little off, and it was picked up by the chat room.
Yeah, the chat picked it up. Awesome, great on the listeners to pick that up. This is typical emergency medicine. I had the first dose right, but forgot about how frequent because I wasn't thinking about the inpatient side. So the dose, if you're doing the treatment dose, so those are the sicker patients that are going to the unit, we were talking about 1 mg per kg BID or 1.5 mg per kg once a day. So the video was incorrect. We will update that and fix it. And I want to just give a shout out to our great viewers who picked that one up. 1 mg per kg BID or 1.5 mg per kg once a day for the sicker patients that you're thinking about giving that escalated or elevated prophylactic dosing to.
Of course, to be honest, we have no idea what the right dose is until we get the studies out. So one question that comes up a lot, and it even came up a lot last night when I was there with Britt, is what about the vaccination safety in pregnancy and lactation? Does anybody want to take a stab at that?
Yeah, I'd be happy to do it, Mel. As far as the FDA is really coming down saying they don't have an opinion, basically, but ACOG and some of the other groups have said if there's no other reason why a pregnant female can't get a vaccination, that they shouldn't. So there's probably more information to come, but it seems like, at least at this stage, it's safe, and I would extend that to with breastfeeding as well.
One thing that I'll add to that is that the data on Moderna's trial were released today in advance of the FDA meeting for tomorrow, and there were a group of women who became pregnant during the Moderna trial, and they did not have any difference in outcome compared to the women in the placebo group.
Do we know how many people were in that? How many that was?
I knew it this morning when I read it, but I don't remember right now. I can find it for you.
Well, while I've got you, I think I heard it on This Week in Virology that Moderna is actually presenting some data about infectivity, not just symptoms. So you need to understand that the vaccine trial so far has been about, do we reduce symptoms, do we reduce severe disease, but we haven't had any information about whether you can still excrete the virus and so therefore still be infectious. Did they present some data to the FDA that maybe this vaccine is actually reducing your ability to excrete the virus?
They looked at viral levels in nasal swabs after the first administration of the vaccine. It's a relatively small number, but there is a reduction of about 2/3 in vaccine recipients in terms of virus in nasal swabs and how many of them are positive. But it's in the supplemental part of the Moderna report, so not even in the main 92 pages. And it's a very small number of people.
Somebody in the chat room said that they believe that there were 23 pregnant women in that subset. So not a huge number, but it's actually much more than I would have thought. So We will probably hear more about that tomorrow. Tomorrow's Thursday, so tomorrow you can actually watch the FDA's discussion about Moderna's vaccine. And if you're not working, it's a really great thing to put on in the background and listen to, because there is an enormous amount of information transfer that occurs. What about vitamin D? I think we've got to talk about that. Sean, give us your thoughts about that, because lots and lots of people are talking about it. There's this association that you talked about. There's Dr. Fauci said that he was taking supplements. Can you give us any more color on vitamin D?
Well, I think it's really, as we said earlier, it's hard to say. I think that the study that we had talked about actually used vitamin D3. I think more people are more familiar with ergocalciferol, which is a vitamin D2. The dosage that they used were pretty high. So it was vitamin D3. They were using 500 mics once a day, and then 266 mics on day 3, 7, and then weekly after that. Vitamin D, though, remember, if you can get hypercalcemic if you take high doses, but there's a lot of data just for kind of all causes, if you will, that people with lower vitamin D don't do as well. And as we were talking in kind of the chat room, Mel, you mentioned people who are darker pigmented or maybe in latitudes that don't get sun. So I think that there's probably benefit in people who have documented or suspected low vitamin D to bring them back to the normal range. But as far as a treatment for COVID, I just think the data's not there yet.
So a question here in the chat room that I'm reading, it says, how long after the first dose until you develop immunity? And I can take the first stab at this. In the Pfizer study, it looked like by day 12, after the first dose, the curve started to come apart. So maybe 50% efficacy by around after the first dose by about 2 weeks, say. And then they got the 95% efficacy about 7 days after the second dose. What if I get infected after the first dose? You got infected after the first dose. You probably won't get a severe disease if it was 10 to 14 days after that, or at least it'll reduce your chance. If you've had prior COVID, you get the vaccine. This is something that comes up all the time. And the answer that I understand, and please jump in, Brianne, if I'm wrong, is that the FDA is saying if you are known to have been COVID infected in the last 3 months, don't get the vaccine. And my understanding is not because they're worried that you're going to have some hyperimmune response to that, but because you probably don't need it and we don't have enough vaccine right now. Is that your understanding?
That's exactly my understanding. I would expect that a person who was COVID positive who got the vaccine would boost their immune response further with the vaccine. But right now we need to make sure that we get doses to as many people as possible.
Okay, so I'm reading some more here. What about health equity in the setting of a crisis of standards of care? I'm not exactly sure what they mean, but do you understand that question, Annette?
Sure, I'm happy to talk about that. So I think part of the question with these crisis standards of care, they're really talking about what we value as society and who we prioritize. And so a lot of these crisis standards of care are talking about lives saved or number of life years saved. And so I think something that we just should be thinking about and should be part of the dialogue is probably what else do we value in society? Because we've seen that communities of color have really been disproportionately affected by this disease on every single level. You know, who gets it, who gets admitted, who ends up dying for it. And so I think our measures, our algorithms when we're triaging should probably account for that as well.
Yeah, there was some discussion on, again, This Week in Virology, my favorite podcast, about whether we should be immunizing the elderly because of the number of life years saved is lower than in young people. But as I understand the statisticians that have looked at this, because the mortality in people over the age of 70 is so high, you actually still save more life years in that group than you do the 30-year-olds because they're much less likely to die, which has raised some of other people's question about, should we really be immunizing with a brand new vaccine people whose chance of having severe disease is very low? Do you got any words to say about that?
So I completely agree. I think that the data that I've seen indicated that people who are older have such a high rate of mortality that vaccinating them is going to be our best bet, especially given that the vaccine seems to do best at preventing disease.
Okay, there's a really good question here about steroids. Are they reasonable in a patient going home on O2? So if we remember the big study, I can't remember what it was called. Was it Recover? I don't remember which one was the original steroid study. Anyway, the group who needed oxygen, who got steroids, did better. And they were admitted mostly. But now we are sending a lot of patients home on oxygen. And I don't think they divided that out. I don't know, Swami, if you know if they divided that out or anybody else. But I think if you're sending somebody home on oxygen, it's not unreasonable to start them on dexamethasone. Any thoughts?
I agree, Mel. I think that they didn't do that in recovery because they weren't having to send the patients home. We have a HOMO2 protocol. And those are patients that if we didn't have a HOMO2 protocol, we'd be admitting and we'd be putting them on Dex. So I think you do the same thing, sending them home. I would put them on dexamethasone when they go home.
Yeah, I agree with that as well. I mean, it just reminds me of the criterion of whether a patient came to the hospital by ambulance or not, and using that in the decision tool. It's like, it depends on where you're at and what the context is. And so there you have it.
Has there been a change in the standard of care in non-COVID patients in this pandemic setting? So again, back to you, Annette.
Mel, do you mind asking that question one more time?
So the question is there a change in the standard of care in non-COVID patients when you do this crisis standards of care?
So the triage criteria will apply to everyone if that crisis standard of care is enacted. So when we're talking about using the SOFA score to determine if someone gets like an ICU bed or a vent, that would be applied to everyone who could potentially need an ICU bed.
So it's not like, oh, you're a COVID, you get this amount of care. You're an MI, you get this amount of care. It's sort of just like, this is the amount of resources we have and we're going to try and distribute it fairly.
Exactly. Everyone's in the same pool.
Okay. There's a question here. Should we advise pregnant patients to get the Moderna, not the Pfizer vaccine, because the data we have is with Moderna? Are these two vaccines that different, Brianne? Would it worry you one way or the other?
I think of those vaccines as being incredibly similar and practically interchangeable, at least in an immune response kind of way, not in a storage kind of way. And so sure, there's a slightly more data on Moderna, but I don't know that there's any reason to pick one or the other in that case.
And maybe just a couple more. Are patients who are receiving biologic agents safe to receive the vaccine? There are so many patients now receiving various biologic agents. We know that many of them produce immune suppression. Should they take the vaccine? Anybody want to take that one? I'll give you mine. Go.
Oh, no. I was just going to say that from everything that I have seen, that seems to be okay, but I would point out that I am the one PhD here who is not an MD, and I would say talk to your doctor.
That's unfortunate. I don't think we have data. But I sort of weigh this up as risk of the virus versus risk of the vaccine. And if I was on a biologic agent, if I was immune suppressed for any reason, and I couldn't lock myself on a desert island or New Zealand or Australia, then I would go with the vaccine. Somebody was chastising me on the chat earlier about, you seem to just like accept that this vaccine's okay and we're just going to do it, and that we don't really have that much data. And my response was, yeah, we don't have that much data. We don't have long-term data, but we have to make a decision. And we do this in medicine all the time. We don't have enough data, but we have to make a decision. We know that COVID's bad. We know that long COVID's bad. We know that lots of people have myocarditis and thrombotic events. And what we have on the data of the vaccines is pretty good. So if you weigh those two, I would say for the vast majority of people, getting the vaccine is the right thing to do. Now, if you're young and healthy, there is actually, I think, some discussion to be had. But then we have to have an ethical question about, if we really want to get to herd immunity, we need to give this to as many people as possible. But I'm really hoping that 6 months from now, we don't find out that there are late vaccine effects that we don't know about. But right now, given the predominance of the evidence, I think you would have to say, for most groups, you should get vaccinated, because this virus is not very nice.
I think that is such a great point. The one other thing I would add is that there are similar mRNA vaccines that have been given since 2013 in phase 1 trials to about 1,400 people, and there have not been any long-term effects in any of those individuals.
Oh, that's great. There's some questions about using PPE after vaccinations, e.g. EMS using N95s for patients despite the fact that they've been immunized. I think once you've been fully immunized, 7 days after your second dose, you're going to have a pretty good immune response. Your chance of developing severe disease will be low, but you should still be wearing a mask if that's what the question is. You might not need to waste an N95 mask, but you should still be wearing a surgical mask because we still don't know whether you can be infected and be spreading it, although we've got a little bit of data from Moderna to suggest that maybe you're not going to be spreading it very much. But I think until we know, masks are easy, leave the mask on, protect your patients. Maybe we'll take one more, or maybe I'll just ask our faculty here, is there anything else that you feel like we should talk about before we go?
Well, I had the one question. I don't know if anyone has the answer to it, but can I get the flu vaccine around the same time that I'm getting my COVID vaccine? Is there any timing? Do we know anything about the timing of those?
I don't think that we know anything about the timing of those. I personally would spread them out just a little bit to make sure that there's time for an effective immune response, but we don't have any data on that.
There are a lot of vaccines that are all piled in together, and particularly in kids. It always seems to me like, my gosh, this kid's immune system is going to get bombarded by 3 to 5 different things at once. So if you can spread it out, I guess that makes sense.
That may be true, but remember, yes, that kid is getting bombarded with a few different microbes at once with those vaccines, but then compare that to the number of microbes you're bombarded with in your daily life, which is certainly many more than are in those vaccines.
There's some comments about how Home O2 protocols and stuff work. I don't know, Britt, if there's anything that in the chapter, or if anybody has any specific protocols that they can point people to, but if we don't have it, we will get some links in the chapter.
Yeah, there's nothing specific in the book chapter. I think this is going to be very, very hospital dependent. Some hospitals have the capability, and it's probably going to depend not even hospital to hospital, but country to country. I know a lot of hospitals are even starting to run out of oxygen for their patients that are in the ICU. So we can add some links and some protocols for that maybe could be found on the CDC website, but we don't have anything right now.
So let's make 2 last comments. One, oxygen concentrators. I was trying to find out how much O2 do you get out of an oxygen concentrator, this magic device that takes the air and squishes it harder. And I think it looks like they're mostly about 2 liters of oxygen. So it's not like you're going to be able to get an oxygen concentrator and be 60 liters a minute kind of thing. And then a question here, which I think we'll find out the answer tomorrow, so this might be a good place to end it, is the onset of immunity with the Moderna vaccine similar to that of Pfizer? And remember, Pfizer said by about 10, 12 days after the first vaccine, you start to see the curves of infections depart. We will probably find that out tomorrow because I don't think we've seen that data yet. So on that note,
the data was in. The data was in the packet today. The
it was?
Curves diverged dramatically at 14 days.
At 14 days after the first dose, there you go.
Yes.
It's nice to have somebody who's actually an expert in the faculty. That's great. So actually on that note, we've been going a long time. It's late on the East Coast. I want to thank all our faculty here. I want to thank all of you that were in the chat room and doing this stuff. So many great questions. We used to do these every week and then every month, and then we went to just when we needed to, felt like we needed to. And so we'll do another one of these when we feel like, because of your input, we should do some more of this. There's many more large trials that are coming. People will be getting the vaccine. We'll be hearing more about vaccine side effects. So we'll be back. But thank you, everybody, for listening. And again, people that are on the front lines. I got to see you in the last week or two up close, what you're doing there. This is going to be a very, very difficult time in some places like Los Angeles, but across the world. And this is the last part, though. This is the war is almost over. And we've just got to try and push through this period. So thank you for your unbelievable work at this time. It's tough, but we can do this together. Talk to you soon.